Good afternoon, everyone. This is Andy Reese, Director of the Department on Disability Services. I'll just say in advance, we don't have any questions, but I am looking forward to people entering any questions or information they'd like to share in the chat. As a reminder, when you do that, make sure in the drop down at the bottom of the chat box that it is to everyone. If you put two participants, then everyone else can see it, and the people who are listed as presenters cannot. I do see in the chat that Daryl Hawkins from DC Health is with us today, as well as Nelson Vanucci from DC Health as well. So just as an update in terms of our data, we did have one additional person test positive this week, and this is a person who is receiving care at home, so they have not required hospitalization. So our numbers at this point in time are: one person is hospitalized, 33 people who have had COVID have died. However, of those, for the ones that we've gotten reports from the Office of the Chief Medical Examiner, 31 are, well, 2 were attributed to something other than COVID. And so our actual deaths reported, if you look at the mayor's website, is 31, which could still be reduced by, there are 4 more where they were questionable, and we're waiting for a final report from OCME on the nature and manner of death. 138 people have not required inpatient care, and 82 have been discharged from the hospital. The total people testing positive, 254. The person this week that tested positive was in a natural home, so that went up by 1. We have now had 25 people in their natural home who have tested positive for COVID-19, 86 in intermediate care facilities, 4 who were in host homes, 2 who were in a nursing home, 27 in residential habilitation placements, and 110 in supported living placements. Amongst staff that work at our provider agencies, there have been 335 people who have tested positive. That's an additional people. 29 of those have worked at more than one agency, and sadly 8 have died. As people may be aware, so I just lost Grace, and because of that, if people are looking at me, you won't be anymore. It may be just my own bandwidth, so I'm stopping the video so that I'm sure that I don't freeze in terms of my speaking. The mayor's order for the public health emergency was to expire today. On October 7th, the mayor issued an order extending the public health emergency through December 31st of this year. You may recall City Council had authorized her to extend into some date in early January. The current order extends it to the end of this year, and we will just, well, we'll see where that goes between now and the end of December. So we received no questions in advance. So if people have any questions, you could please type them in the chat box. As a reminder, please type it to everyone. If people are on the telephone, I think that we have a telephone number or to which they can text a question, but Kirk, or if Charlisa is here, would have to remind me of what that is.
Good afternoon, Director Reese. The number to text to some questions.
In the meantime, the everyone function has been activated, so you can type your questions now. Thank you.
The number will be 202-590-7618. And I'll put it in the chat box as well.
So I don't know if Winslow sees the question in the chat box is for him. If you could please provide some update for people where things stand in terms of the issues regarding the companion authorizations. For people that aren't aware, we, in our amended Appendix K, we added a companion 1 to 2 rate. And so we have a number of people who'd been authorized for companion going back to the beginning of the public health emergency who were actual, and the 1 to 2 rate was retroactive to the beginning of the public health emergency. But we have some folks who were getting 1 to 3 instead of 1 to 2.
Yeah, so we have had need to make some internal changes within our system that authorizes the 1 to 2 because we didn't have a drop down previously in the MCI system where service coordinators actually authorize the service. That has been added. So service coordinators will be getting a blast email in probably like 3 minutes because the final touches have been completed with the MCIS. We have the choice of provider form amended to add the 1 to 2. So the issue, well, the only concern and the last piece that I had to add for guidance to the service coordinators is if 3 people lived in a location and 1 person received a companion 1-to-1, that the other 2 would be authorized for a companion 1 to 2. So the system has been updated. Service coordinators are being instructed to amend the ISPs for those people. The waiver unit will backdate the authorizations to the beginning of the public health emergency. And lastly, providers will just have to make adjustments to their billing with regard to the monies that they may have already been paid for the 1 to 3. Hopefully that was clear.
And to the extent there's any follow-up questions, just please type them in the chat. I do see a question for clarification purposes. If a person is in an ICF and wishes to return to their day program, they can, as long as they are able to wear their mask. Is that correct? As I'm reading the guidance regarding ICFs, people's ability to attend a day program outside of the ICF seems more limited than that. Daryl might weigh in on this, but my reading is that people who are in ICFs, really in terms of traveling outside the home, it should be for to go to medical appointments if those cannot be done remotely. And this does not mean that there couldn't be coordination between a day program and the residential provider for the active treatment dollars to be paid to the day program if the day program were to provide the services at the home. But as I read the guidance for ICFs, for phase 2, really people traveling out is more limited than that.
Director Reese, this is Daryl from DC Health. That's correct, what you just described for ICF settings.
And so the comment, it's a question, but it's phrased as a question. So our day program is getting ready to reopen. Some providers are hesitating sending their persons. What do you suggest? Well, as a reminder to people, so day programs are developing their reopening plans, which will address all of the mitigation strategies they have in place to provide supports for people who will come to their day program. As I think I've said pretty clearly and regularly on these calls, I'm hopeful that no one has the expectation that that means that we would have day programs that look like they looked in January of 2020. And, when we talk about people needing appropriate physical distance between each other, it doesn't mean that you have, and this is addressed when the day program reopening plans are considered and approved. It doesn't mean that you just have enough space for someone to come in and sit in a space and they can keep, at least 6 feet of distance from other people. It means a real recognition of the activities they'll be involved in during the day and moving around, and will they be able to maintain safe physical distance throughout the day, with that issue being considered. So as the day program reopening plans are complete, those plans are then being sent to service coordination and to the provider. And at that point, an interdisciplinary team meeting can happen based on the community participation assessment and questionnaire that has been completed. And then they will look at what kinds of activities during the day are important to this person and important for this person in supporting them in their life, and what's important to them, and what kinds of habilitation needs they have, what kinds of activities are they interested in engaging in, and what kind of supports do they need to be able to engage in those services or in those activities. So even when people are returning today, what we're seeing is people returning fewer hours per day, fewer days per week. That day program is a portion of what they're doing. So, it's the interdisciplinary team meeting is a whole discussion about what the person's life and their individual days look like. So all of those, what I suggest is that all of those things get discussed at that meeting, including, and I know that we have one day provider that early on in the pandemic worked with one of our residential providers and said, I have all of this staff who have been providing supports to your people during the day, and you've only been providing supports outside of the day hours. We can work with you to help bolster your staff so that my staff will come in during the day and support your folks. And the other thing is, working with the residential provider around, working with the whole team. What are the activities that the person will engage in, and which is the most appropriate provider to provide those to support the person in engaging in those activities. Oh, geez. Sorry, I'm getting ahead of myself reading the comments, and I hope that Winslow is reading the comments as well. So I'll just say up front, one of the things that's confusing about the companion rate is that we used to have 1-to-1 and 1-to-3 companion rates. What that meant was that we had 2 companion rates. The first one had a modifier that included a 1, which happened to be 1-to-1. The second one had a modifier that included the number 2 because it was the second rate, but was the 1-to-3 rate. And then for the Appendix K, we developed a third rate, which has a modifier that says 3 and is the 1-to-2 rate. Unfortunately, it appears that the description somewhere says says that both of them are described as 1-to-3. So Winslow, if you could read through those comments and provide clarification for people, thank you.
As you stated, prior to having the 1-to-2, if there were 2 people, they would be receiving the same authorization code. So, and also, as Director Reese has pointed out, we only had 2 companion services, 1-to-1 and 1-to-3. So 1-to-3 had a modifier code of, I believe it's U2. Now that we have a third companion service, which is companion 1-to-2, it's now using the modifier code U3. I'm sorry, U2. I'm sorry, U3. So the simple way to look at it, if there are 3 people, the code is 2. If there are 2 people, the code is 3. So, and we apologize for any confusion that has brought out. And with regard to the system, DHCF has our amendment or our change that we've made, and I don't know if they've made the change within their system, and I'll follow up with them today.
So there was a question about the mayor's order. Does the extension of the mayor's order extend pre-authorization for companion care? Not explicitly, but what I will say is that the mayor's order extends the public health emergency, and our Appendix K is in effect through March 10th, 2021, or the end of the public health emergency, whichever comes first. So at this time, the federal public health emergency was extended into early January. The local public health emergency is extended to December 31st, and the end of the Appendix K at this time is March 10th, 2021. And so everything in the Appendix K continues.
And also, I'd just like to respond, the question of a person being in supported living and receiving companion who wants to return to the day program virtually, that cannot happen. That cannot happen because 2 services, at no time can 2 services be billed at the same time. And so that needs to be worked out. The person wants less hours of companion, that can be worked out where they can do 4 hours of companion and maybe 2 hours of virtual day, which seems a bit of a lift and a stretch, because I've had this discussion early on during the pandemic when people started talking about providing remote support. No one's going to sit on a computer for 4 hours and be supported virtually. It just doesn't seem reasonable to expect that someone will receive that service that long. So, these services can be modified, but keep in mind, you have to think about the time. And it has to be worked out with the ISP and being amended and people actually, working reasonably, because if you're ever audited, there's no way that you're going to be able to explain how you were providing virtual day hab and the companion provider was providing companion. It just can't happen. So please don't put yourself in that situation, and work with the team if you want to work this out. Also, we did receive some concerns addressed to us not in the form of a question, but day habilitation providers making known their concerns that the current day provider may be providing companion and unwilling to support the person going back to the day program. And I think this was touched on a bit, but that's a team decision. It's not a provider decision. So we definitely have to ensure that we're respecting the wishes of the person and considering their safety with regard to this pandemic.
So there's a question that we understand that waiver has put a warning that service authorization won't be possible. I don't know for what, if you're talking about companion. Please, we need a grace period, as we thought that service authorization would be renewed by all means during the pandemic. We have a few cases where service authorizations were not renewed since May, and we're providing services on a regular basis. I don't completely understand that question because it feels like there aren't enough specifics, but maybe you understand it, Winslow, and can respond.
So initially, when the public health emergency had a time frame, authorizations were let for a period of time, and then when the public health emergency was extended, we were told that the IT team would be able to go in and do a mass extension of authorizations. And I have not heard this being a problem, but if it is, I will follow up with our IT team, who had assured me that we wouldn't have to go in and do individual authorizations for the extension of service. In other words, if at one point there were 500 or 600 people receiving a service that had a time specific service end date based off of the initial pandemic discussions and timeframes, and then it was extended, and we did a mass authorization of all of those services to extend. So if you have not received the extension, then please reach out to I would say reach out to the individual service coordinators, and to service coordination, I would ask that you share that data with me, because we were told that this was not going to be an issue.
Thank you. Oh, they're saying there's a concern that service authorizations won't be backdated.
Well,
That needs to be clarified.
if it's related to the companion, we have assurances from the head of the waiver unit that that can happen. We don't believe in backdating. We preach to providers that you're not supposed to provide services without an authorization, but we do recognize that there are times when, emergencies happen, or, ISPs may be not approved on time and services are continued. But as a rule, we don't backdate. But in cases where we have a strong, we can explain this to CMS if we're audited, why this backdating was needed, because we did not have the service in place at the time, but it should have been put in the initial Appendix K, made known to us by providers that this was a challenge for them. So, yeah, they will be backdated based off of the change in the Appendix K.
So next, just for clarification, I have a scheduled, it says a community participation assessment questionnaire meeting, which would be the interdisciplinary team meeting for people I serve that reside in an ICF. If the day program can't provide services in the home, then they should not be returning to the day program at this time. It seems to me, however, there should still be a discussion by the team about the services, what they are and who will be providing them. So I wouldn't want to foreclose the interdisciplinary team meeting because there are limitations that are more strict limitations based on the perceived, increased risk in terms of developing COVID and the increased risk of serious outcome from COVID in this instance. But there should still be the discussion because there may be other services that you provide that could be provided at this time. And it just seems to me that the discussion should go forward with the understanding of, and it would be very helpful probably for all of the folks involved to review the relevant guidance from DC Health prior to the meeting so that you're clear about what the options are. But then with those options in mind, what exactly does this person's day look like? I want to take advantage once again here to remind people that even during the stay-at-home order, when we were all required to stay at home, there was an exception for us to go out in the community, to exercise, to go for a walk, to go to the park, as long as we were not, engaging in certain activities. And that kind of activity continues to be essential for all of us. People need to be maintaining their underlying health and well-being, which includes getting out, and also includes making sure that they're following up with any routine health care that they should be getting and consulting with their doctor about whether that routine health care is provided still via telehealth or in person at the doctor's office, or in some instances, in an ICF, the doctor may come to the home. So, it is essential that people are caring for their underlying health and wellness during this time. Please clarify if the mayor's order changes the phase 2 status. I received an email that since the mayor's order is extended, people can't return to the day program. So the mayor's order extends the public health emergency. The district continues to be in phase 2. For guidance regarding the metrics that DC Health and the mayor are tracking to determine when the district should move from phase 2 to phase 3, you should go to coronavirus.dc.gov, and you can see what our status is in terms of the number of different metrics they're watching to determine that at that point, it's safe to sort of loosen things up a little for all of us. There was a really good reference in an article in the Washington Post today that spoke to kind of the different percentages that DC Health is seeing as they're doing contact tracing about where it is these transmissions are occurring. I guess I should have cut it out, brought it in, and told you what they were. Sorry, I did not do that. But it was very interesting to me to look at because it just defined for people kind of, here's the different kind of activities people have engaged in or places they've gone to that represent the higher risk in terms of people having contracted COVID. Things like traveling out of town, visiting with family, going to a restaurant, and it gave the respective percentages that were reflected in terms of that the person had gotten COVID from that. So anyway, I would invite people, once again, if you look at www.coronavirus.dc.gov, you will see under data where the district is in terms of moving from phase 2 to phase 3. And let me just say here that phase 3 will be some relaxing. It's phase 4 where we will start to see a real ability for people to safely travel outside. Even then, I expect people would do so with some caution. Phase 4 is when there is when an effective vaccine is available, and that's going to be quite some time. So even if we got to phase 3, we would still have CPAC meetings. We would still have all the rules about physical distancing. We would still have all the rules about masking. COVID would still be there. The possibility of getting it in the community would be reduced because the incidence of COVID in the community is reduced. The fewer people have it, the less likelihood you're going to get it because it's just not as prevalent. So they're watching those issues in order to track when it's safer to step back a little bit. But just as a reminder, even when it gets relaxed some, that doesn't relax all the measures that each of us needs to be taking all the time of wearing masks, keeping a safe physical distance, regular hand washing. So for sorry. How is billing processed for a person in supported living who is at home with companion supports and day services now want to complete virtual? Oh, I think this is what Winslow already answered. Can both supported living companion and day program bill for the same time? No. And this applies to anything. You cannot receive 2 Medicaid services at the same time. Those issues can be resolved through the interdisciplinary team meeting through coordination. Keeping in mind that historically we have billed, providers have day programs have been 6 hours a day. And providers' rate for residential supports includes all but 8 hours a day. So there's this little 2-hour window, although providers have been having to fill that little 2-hour window up until now, the residential providers. So, I know that there have been some day providers that have done some remote work during those 2 hours where the residential provider was only billing for 6. So there were 2 hours that had not been billed for. But as Winslow said, you want to be very careful as a provider not to bill for 2 Medicaid services at the same time. A person cannot be receiving 2 services at the same time. As day programs are reopening, can day programs require a person supported have a COVID test when there is no obvious reason? For example, they don't meet any criteria for testing in order for the person to return to the day program. So neither DC Health nor the guidance by DDS, the best practice guide regarding reopening day programs, include any recommendation for pre-admission or routine testing of either staff or the people who attend a day program. But all that means is that it's not a requirement. What I have heard anecdotally from many family members who would like to see their family member return to a day program is a real concern about this question. And they have asked the question, are they going to be testing people before they come? So in developing their plans, some of our day providers are including that there would be a sort of pre-enrollment COVID test by the person. That's not required by either DC Health or DDS, but it's not prohibited. So can they require it? Yes, they could require it. And is there, I don't see that there'd be a DC Health prohibition on that, but if DC Health could just weigh in on that, that would be helpful.
Hi, Director Reese. You're correct. We do not have it's not a requirement from DC Health, but and we don't have a prohibition of day programs deciding for their own policies to go stricter than what DC Health requires. Thank you.
So the next question is, can you provide guidance on where we can find, hold on, let me see. Can you please let us know where we can find the guidance regarding return to day programs for ICFs? Service
Director Reese, I
coordinators are
did.
scheduling CPAC meetings. And so we'd like to, review those, which I think would be helpful. And I'm just going to pull up the DDS guidance that it's DC Health guidance that was issued regarding ICFs. And this guidance can be found, it was issued August the 5th, can be found on our website. It can also be found at coronavirus.dc.gov as well, at either of those. And I will copy the web address here.
And Director
Yes.
Reese, I put the link and the title of the DC Health Guidance in the chat also.
Great. Okay. So we've got
ICFs.
both ways you can get it. Oh, so all of us have given you the link. So if you look in the chat box, you will see Daryl Winslow and I all have posted for you where you can find this information. And what this is not specific to returning today. It is the specific guidance for ICF. So it addresses all issues related to ICFs. Is it possible at this point in time to find more COVID-19 supplies such as masks? I have not heard issues with supply, so maybe other people can comment on that.
Director Reese, what I would say is that I have been able to personally find a lot of supply on Amazon as well as other distributors of those kind of products. So I would really urge this provider to take a look at Amazon.com and other retailers. I think there's been an increase in supply in recent weeks and months. So that's my advice there.
And this is DC Health. What I can share is that our colleagues at HEPRA and DC HMC have not reported any shortages on face masks as PPE supply in the district as of yet. Thank you.
Director Reese, would you like me to take over reading the questions to make it a little bit easier for the flow?
I think I'm doing okay.
No, you're doing fine. Just wanted to make sure I can.
Okay. I'm okay. Thank you. So thanks for the clarity. It says we can't do virtual remote, Mr. Winslow. Providers are not willing, SL providers, to give up hours to support a person virtually. So I guess I'd have a couple of responses to that. One being SL can include supported living periodic, in which case they're being paid by the hour and it's much easier. The other is to keep in mind that if a person is supported in the home and their current ISP calls for them to have staff 24 hours a day, even if, like whatever the staffing ratio, the SL provider cannot decide to not have that available. We have allowed for flexibility in providing that remotely. So if it could be worked out that some of that is remote and provided by another agency, the concern that many providers I expect would have is if something's happening in the home, they are responsible for it. So even if they want to shift to remote, they're going to want their own staff doing it remotely, would be my guess. But I don't know that this applies to all providers. I am not surprised that you would have this issue with some providers or even many providers. In my discussions with residential providers, they feel a very real sense of responsibility for ensuring the health and safety of the people that they support residentially. And so they are somewhat protective, and they're going to make sure that, that that adequate supports and care are in place for people that they're responsible for. So from DOH, given that the new system does not pull background checks for already eligible employees from other providers, does this mean that they have to schedule for fingerprints every time they apply to a different agency, even though they're the same person and are already eligible for one provider? I'm trying to remember if background checks was one of the things that was waived in the Appendix K.
It was.
Okay, so no, because that was waived. And what was included is a time frame at the end, within a certain number of days by the end, that a person did have to obtain the clearance. The next question, is there an option for provisional hire? That would be it. And even the requirement to, is there a requirement to redo fingerprints? So do we do ongoing clearances or do we just do a pre-hire clearance?
That's also waived with regard to timelines to extend after. So if a person needed to resubmit, this, from our Appendix K, the district is seeking temporary authority to suspend the following qualification requirements for DSP staff: initial and annual training, including CPR and first aid, pre-service and in-service training described in the policy, until 45 days at the end of the pandemic. Provider agencies may choose to provide online training, such as CPR and first aid in lieu of the training. Online CPR and first aid trainings offered during the public health emergency are effective only 45 days after the end of the pandemic. Pre-employment background checks until after the end of the public health emergency. Read.
Thank you. And I expect Grace thanks you for the exercise she got there. That was very.
Oh, I'm sorry, Grace. I'm so sorry.
So for DC Health, is there any information in any of the guidance that's been issued that requires that there be hand sanitizers in people's bedrooms?
Hi, Director Reese. This is Hawkins. So, no. What we do say is that ensure that there is availability for hand hygiene for the direct care staff and persons living in the home, but we do not specify where it has to be. For example, personal travel size alcohol-based hand rubs may be more feasible for direct care providers to have, depending on the persons that they support and their needs. So I will say, though, that behaviorally speaking, what we note is that people comply to hand hygiene the more readily available it is to them. So that's the only consideration, but we do not require it to be in a room of a person. Thank you.
And I'll just say, from my own, like going way back in history, when I used to work on adherence issues regarding people taking medicine, it was, the important thing was keeping it in front of the person. So it would be the same thing with the hand hygiene. If it's sitting where you see it, you will use it. And that would be the benefit of having hand sanitizer, like I have it right here on my desk in front of me, having hand sanitizer in your bedroom on the dresser so that when you see it, you use it. So my understanding, this is a question, not my understanding, is that the interdisciplinary team meeting from the community participation and assessment and questionnaire is held to determine if the person will return to the day program or not. Since ICF are not allowed, is it necessary to have a meeting for people who are in an ICF? So let me just remind people, I pulled up the community participation assessment and questionnaire. The purpose of this assessment is to guide in the development of a customized community participation plan. the community participation assessment and questionnaire meeting is not required for people to participate in community activities with their current provider. The CPAC provides guidance to the interdisciplinary team to mitigate identified risks. The meeting is helping to assess the need for amendments to a pre-COVID day service authorization. So to be clear, it's not just to say, and this is, I mean, this feels related to what I said before. It's not like we had an authorization in place before for day habilitation, and it was 5 days a week, 30 hours. So let's come back together. Do we turn that on or not? It is looking at where the person, looking at the person in terms of their risk factors in terms of the possibility of contracting COVID, which would be things about their understanding about using PPE, their ability to use it, their willingness to use it, their recognition of the, their ability while they're in the home to do regular hand washing, to use face masks when necessary, to maintain physical distance, and then also looking at underlying issues that might indicate that this person, if they were to contract COVID, is at higher risk for serious outcomes. So understanding this person in terms of their risks, and then also understanding how have they been coping at home? What is it that since they have not been receiving those day services, what are they doing? What do they want to be doing? What do they need to be doing? And what supports do they need in order to engage in those things that are important to them and that are important for them in terms of their health, safety, and development. So it's about all of that. It's not a sort of yes, no, it's a real comprehensive, individualized look at what does this person need right now, and how do we, in the safest way possible, help them to achieve it. I would like to know if measures have been taken by MTM to resume transportation. If no, how are persons going to be transported from their homes to their various day programs? MTM was here previously on this call, and they walked through the strategies that they have taken and the mechanisms that people can use to engage them as a resource for transportation. The question of how a person is going to go to their day program is one of the questions that would be considered at the interdisciplinary team meeting. One of our biggest one of my biggest concerns when I think about day programs reopening is, what does it look like at 9 o'clock in the morning or 8 o'clock in the morning when people are arriving? Because I sure don't want to see a mass of people standing around outside the day program, standing close together, with or without masks. So one of the issues that gets discussed, one of the issues that's addressed for the reopening plans for day programs is, how do you manage bringing people in at the beginning of their day? And then one of the issues that would be discussed with the interdisciplinary team meeting is, if this person is engaging in day services, how will they get there? And regardless of how they got there before, what's a safe way for them to get there now? There were people who were going to day programs who used Metro, and they may use Metro again. The question I would have is, do they have the supports, or if any are needed, do they understand how to keep themselves safe while traveling either on the bus or the Metro train? It is possible to do. For people that travel on the train, the trains are not crowded at all these days. Safe physical distance is easy. remembering not to touch the railing while you go down the escalator, if you're able to go down without touching, or keeping hand sanitizer with you to wash your hands as soon as you did come down the escalator. Remembering to keep your mask on, remembering to keep a distance from people, making extra sure not to touch your face, while you're riding on the metro, making sure that as soon as you arrive at your destination, you wash your hands. All of these kinds of things, I would hope, are the kinds of things that are talked about at that interdisciplinary team meeting, because you're talking here about a person who's now re-engaging and talking them through how comfortable are they taking these steps now. Some people might say, I used to take MTM, but I don't want to because I know I'm not going to be the only one on that bus. And I don't want to sit in a van with other people. Can we talk about another way for me to get there? Or maybe the team is concerned about that and they raise with the person, are you sure this is the best way to get there? Or you talk to MTM. How many people will be on the transportation? How do you manage all of these things? MTM did provide us information about those questions, and I'm sure they'd be happy to follow up with people on those questions. When will healthcare finance start informing families about EVV? I'm looking to see who's here who might be able to answer your question.
Director Reese, I've just added Donald Clark, who can provide a little bit more information on that.
Wonderful. Thank
Donald,
you.
are you able to speak?
So Donald, you're a participant, but you're on mute. Or, yeah. You're
Thank you.
listed actually as a presenter, but on mute. Go. Oh, good.
Yeah, I'm here. Thank you. Yes, DHCF, I can confirm that letters started to be received this week. The reason why is because I actually received a question from a parent of a person who will be impacted by EVB. In addition to that, I just wanted to state, besides letters being a form of notification to people receiving services and support in their family members, DHCF has also encouraged during the monthly stakeholder meetings that providers also start to inform beneficiaries and family members when they are available to do so. We have also been doing our efforts to make sure that all of our stakeholder engagement events, EVV has been able to present. And most importantly, I work with Deputy Director Woodland scheduled for EVV presentation to service coordination, because as we all know, they are very vital contact to our people we support and family members. So we want them to have that high level information as well. Just wanted to also share, please feel free as providers to direct family members and people supported to the EVV website, as well as send any questions to evvinfo@dc.gov. That's another way you can ask questions, and that's very important because those questions, if they're repeated questions, go into the frequently asked questions on the website, so people can find information there for some of those questions. So I'll put that in the chat as well, the EVV info for any questions, and also the website link.
So there's a comment here that the question regarding background checks was not about during the pandemic, but for any update afterwards. And I'm hoping that Winslow's information from the Appendix K answered that question. I believe the answer was within 45 days after the end, those clearances need to be in place. Will DC Health be updating their ICF guidance to reflect visitation rules that will recognize what CMS has in the context of much bigger nursing homes, that people derive value from physical and emotional support they receive through in-person visitation from family and friends?
Hi there. So, yeah, we do want to acknowledge that that in all healthcare settings, including nursing homes, ICFs, that visiting with your family in person is valuable and is important and crucial. What I will say is that, um, as we've told even the nursing homes in the DC Health area at this time, um, that nursing homes, ICFs, should still follow the DC Health guidance, which is we do encourage visitation in person, but outdoors and not inside, unless for compassionate care situations. Um, and uh, so at this time, DC Health guidance is is still outdoor visitation in nursing homes and ICFs, um, except for compassionate care. Thank you.
So can we have someone from DOH background check system assist with concerns asked earlier regarding their new updates? I don't know what DOH background check is done. And I don't know if we have Sharon Mebane on, if she would know what you're referring to, and maybe Winslow does.
I think Sharon is on the call, but I have weekly calls with DC Health, and I have not heard of any changes to the background check system. The Appendix K speaks to the waiver settings. So Sharon, if you could answer whether you guys have any changes that you've made to the background check system. Sharon, are you on?
She's on, but on mute, but I'm not sure if she may have stepped away. So I assume, is that then a question about background checks for people in ICFs, for staff at ICFs? Because that would not be covered by the Appendix K. But it would have been covered by their 1130.
Hi, this is
Good.
Sharon
Hello.
Ribbon. Hi, sorry about that. So right now the requirement is any pre employment, they must have a background check that is required for all employees, new employees. And if they're switching from job to job, new provider, they need to also have a background check.
And that applies to just ICFs, I assume?
No, any unlicensed personnel. Licensed personnel such as nurses are not required. They have a background check done at the time of licensure. That's in Title 22B, Chapter 47.
But there's the flexibility for our staff in supported living, for our waiver staff that says that's waived. So we may need to discuss this with you. We don't have a call this coming Monday because I keep forgetting that we won't be here Monday. But perhaps we should just make sure that we discuss this and make sure that we're all on the same page and then come back a week from Friday for folks.
Yep, and I will talk with my criminal background check division just to double check on that requirement.
We have someone asking Kirk to be unmuted to speak to the background check question.
He's
I'll defer to Director Reese. We are pretty much at time, so I don't know.
yeah, so we're about out of time, and I think the best answer at this time is that DC Health and DDS will clarify the DC Health regulation that Ms. Mebane is referencing there versus what is included in our Appendix K and what applies to all how that applies to each different kind of staff person. And we'll provide that feedback to people. That'll be a week from Friday because we typically have our conversation weekly with DC Health on Mondays. And, well,
I
was going to say, like, what's that?
I was going to say, Sharon's been very gracious to kind of be flexible. So if Sharon, you find the answer, you can call me,
Yeah.
and let me know.
I'll research it today and I'll give you a call, Winslow.
Okay, so we're now actually at 1:06. So thank you to everyone. And, as we saw, even though we did not have questions coming into the meeting, we certainly do have a lot to discuss. I want to thank people for their participation in this. And I think it's a really useful ongoing dialogue. And we will talk with everyone next week.